Thank you for joining us today for our session with Windmill Cardiovascular Systems and Dr. Bartoli. My name is Shane. I run the events over at 10 Capital Network, and we're really excited for today's event. I want to bring Hall Martin up, our CEO, to get things started. But just before he does that, just want to remind everybody in the audience, if you do have a question, you can put that in our chat box. And also, don't forget to answer the poll at the end of the session. That way we can gauge your interest and follow up as necessary. So with that, Hall, why don't you go ahead and take it away?
Great. Thanks, Shane. I want to thank everybody for joining us today. We have another great presentation. Today, the title is Challenges and Opportunities of End-Stage Heart Failure Patients. We have with us today Dr. Carlo Bartoli, MD, PhD, cardiac surgeon and assistant professor at Geisinger Medical Center. Dr. Bartoli, thank you for joining us. Can you come on up and let's have you introduce yourself, tell them a little bit about your background, and then want to hear your take on this topic.
Hey, good afternoon, everyone. So I have a slide deck that includes a little bit of professional background. So if you want me to just share my screen, I can bring this up and then we can jump right in. Is that okay?
Yeah, that'd be great.
Great. Thanks, everyone, for joining us. These are my relevant disclosures. I've been collaborating with Windmill Cardiovascular for 6 or 7 years now. I'm on their medical advisory board, and then we also have funding through the NIH for the development of this device that I'll be talking about. A little bit of professional background about me. I'm the director of pediatric and adult congenital cardiac surgery at Geisinger Medical Center in Danville, Pennsylvania. I'm also the principal investigator of a translational biophysics laboratory, which was previously at the University of Pennsylvania. And then more recently, we've moved to Geisinger here in central Pennsylvania. And the focus of my laboratory for the past 10 years or so has been artificial circulation, blood trauma, and angiogenesis. And so we've been able to raise about $6 million in scientific funding, primarily for artificial circulation and device development. We've published over 75 articles and given 65 national and international talks in this space. We've won multiple national and international scientific awards. But really, the major goals of my laboratory are twofold. Number one, to advance the field of cardiovascular medicine, which is really the reason that I'm here. And then number two, to mentor and train the next generation of physician scientists. So let's jump right in. Current generation continuous flow, or what we refer to as non-pulsatile flow LVADs, are now standard therapy for patients with advanced life-threatening heart failure. And so these devices are implanted via sternotomy. We open the chest, and then we put the patient on the heart-lung machine, which is cardiopulmonary bypass. So this is a big undertaking. These devices provide anywhere from 0.5 liter to 10 liters of blood flow per minute in order to meet the metabolic demands of the body in heart failure. And at 75% survival at 6 months in pediatric patients and about 75% survival at 2 years in adult patients, outcomes are decent. However, outcomes and quality of life are significantly limited by adverse events, which we now understand are in large part due to how these devices deliver non-pulsatile blood flow to the body. And so to highlight this point, these are some intraoperative tracings from an adult patient in heart failure. And then this is the same patient after we've implanted a non-pulsatile LVAD. So the blue tracing is blood pressure in the arteries. So this is your arterial blood pressure. And then the black tracing is blood pressure inside of the heart. And what you'll notice is that after the device has been implanted, the peak pressure of the heart never exceeds the pressure in the arteries. And so the patient's blood pressure remains flat or non-pulsatile. And so if you were to feel the patient's wrist or their neck for a pulse, the pulse would be totally absent. And so without going into too much detail, we know that non-pulsatile LVADs generate non-physiologic blood flow. So how do they do this? These devices have an impeller. An impeller is much like a propeller behind a boat. The current generation devices are not smart. The impeller is set at a fixed speed, a very fast speed, anywhere from 2,000 to 30,000 revolutions per minute. And so as this impeller is spinning, it generates an average shear stress of anywhere from about 30 to 150 pascals, and a peak shear stress of anywhere from 1,500 to 3,000 pascals. So I think it's important to note, normal shear stress in the body is 2 to 8 pascals. So these devices are generating shear stress that it's at least 2 orders of magnitude greater than normal physiologic values. And so crucial to understanding LVAD pathology and the shortcomings of the current generation of devices is the concept that non-pulsatile flow LVADs generate supraphysiologic shear stress. So I really want to emphasize this point. There's no physiology in nature, in mammals, in which shear stress exists this high. What are the consequences of LVAD shear stress? Well, blood trauma. This is somewhat of a grab bag term that we use to characterize biological consequences in these patients. Von Willebrand factor, which is a clotting factor, is degraded. Platelets and white blood cells are activated and develop dysfunction. These patients develop hemolysis, which is the destruction of red blood cells. They develop microparticles in the blood, which are fragments of cell membranes that are circulating throughout the body, and then inflammation. And so these biological consequences have clinical consequences in these patients. Bleeding, the development of arteriovenous malformations, which are vascular malformations, device thrombosis or clotting, thromboembolism when the clot breaks off and travels somewhere else, and for example, can cause stroke, and infection. So these are a lot of adverse events that these patients are having. So patients with current generation LVADs are having many life-changing and often life-ending adverse events. And so to highlight this point another way, these are the results of the recent Momentum 3 clinical trial, in which outcomes with the previous generation HeartMate 2 LVAD were compared against the current generation gold standard HeartMate 3 LVAD. And it's worth mentioning that the HeartMate 3 is currently the only clinically approved left ventricular assist device in the United States. So if I have a patient that's in advanced stages of heart failure, this is the only device that I can offer them. And you can see that this is causing significant numbers of adverse events in these patients. To circle back to this concept of high shear stress, there's now significant and irrefutable evidence that LVAD shear stress causes blood trauma, which leads to adverse events. And so another way of thinking about this, if you take this goldfish and you have him swim through the HeartMate 3, again, the HeartMate 3 is the gold standard device that we implant. It's the only clinically approved left ventricular assist device in the United States. Spinning at 5,800 revolutions per minute, you're basically putting him in a blender. And so again, we know that LVAD shear stress and non-pulsatile blood flow are major determinants of blood trauma and adverse events. So this has led the field to acknowledge that safer next generation devices with pulsatile blood flow and low shear stress are urgently needed. Enter the TORVAD, the device that we'd like to discuss today. So the TORVAD is the first of its kind toroidal flow LVAD. We believe this is a disruptive technology with the potential to change the field of artificial circulation and the management of patients with advanced life-threatening heart failure. And the TORVAD stands, in my mind, on 5 pillars of novelty versus prior generation devices. Number 1, the TORVAD delivers pulsatile blood flow. Number 2, the TORVAD has minimal, if any, blood trauma. Number 3, the TORVAD is a smart pump that can accommodate changing physiologic conditions. Number 4, the TORVAD may be implanted via less invasive techniques. And then number 5, TORVAD technology is scalable for different sized devices in different sized patients. And so I'll go through each of these individually, talk a little bit about each of them. So flow delivery is via a totally different mechanism with the TORVAD, a toroidal flow mechanism. Rather than spinning at thousands of revolutions per minute, like the previous generation devices, it spins at 80 to 160 revolutions per minute. So this is comparable to the native heart rate of 80 to 160. Again, it generates pulsatile flow, and this device was designed to generate low shear stress. The peak shear stress that it's generating, not the mean shear stress, the peak shear stress is 10 pascals. And so you can compare this to devices that are generating orders of magnitude higher shear stress than this. How does it work? So the TORVAD is based on the concept of a torus chamber. A torus is much like a donut. There are 2 magnetically actuated pistons that spin within the torus chamber. One piston is always stationary and one piston is always spinning. And so the TORVAD produces pulsatile blood flow with low shear stress. So we've studied this device in my laboratory with human blood, as well as in large animal implants. The TORVAD does not cause platelet activation. The TORVAD does not cause hemolysis. And the TORVAD causes minimal von Willebrand degradation. Out of all of the devices that we've tested in my laboratory, and we've tested many over the years, this causes the least von Willebrand degradation of any device that we've tested. Next, the TORVAD is a smart pump. Unlike the spinning impeller in current generation devices, the TORVAD pistons are able to sense the rate and the back pressure from the native heart, which allows the TORVAD to adapt to changes in heart rate, heart rhythm, blood pressure, and blood volume. Why is this important? So this is the first device that's designed with the ability to automatically accommodate changing physiologic conditions such as exercise, postural changes, so patients standing up and sitting down, sleep-wake cycle, and pathologic conditions that may develop in these patients, such as arrhythmia, high blood pressure, low blood pressure, worsening heart failure, and also changes in blood volume due to the medicines that they take and/or changes in their diet. It's worth mentioning implantation techniques. So when I implant a current generation LVAD, I perform a sternotomy. So I open the chest, access the heart. I then put the patient on the heart-lung machine and expose them to the risks and consequences of cardiopulmonary bypass. And these patients come out with a large scar. In contrast, the TORVAD, as well as some other devices, can be implanted via a less invasive technique that does not require cardiopulmonary bypass and leads to smaller scars. But ultimately, and this is really exciting for the field, the design of the TORVAD will ultimately allow minimally invasive techniques via vessels in the shoulder without entering the chest, and only a small scar that's similar to how a pacemaker is implanted. Finally, with computational modeling tools, it's been demonstrated that this technology is scalable. And so one could envision a family of different sized TORVADs for different sized patients. And as someone who operates on infants and children, this is especially exciting for me, as we do not currently have great options for these devices in pediatric patients. So in conclusion, current generation LVADs with non-pulsatile blood flow and high shear stress cause blood trauma and frequent adverse events, which can be life-changing and sometimes life-ending. In contrast, the TORVAD is designed with pulsatile blood flow and low shear stress and does not cause blood trauma. Number 3, the TORVAD is a smart pump with intelligent sensing and adaptability for a variety of physiologic conditions. The TORVAD may ultimately be implanted without entering a body cavity or cardiopulmonary bypass. TORVAD technology is scalable for different sized devices in different sized patients. And lastly, this disruptive technology has, in my mind, the potential to change the field of artificial circulation and help many patients with heart failure. So as a final thought, I want to circle back to the image of a fish in a blender. So this is the TORVAD device, and it's pumping 5 liters of blood flow per minute. No fish trauma. Show that one more time. I think this highlights well the concept that this device does not cause blood trauma. I'd like to thank Richard and the Windmill team. They've been outstanding collaborators over the last 6 or 7 years, and I'll take questions.
Great. Thank you, Dr. Bartoli. That's a great presentation there. Very clear what's going on. My first question is, how long do people normally live with the current LVADs that are on the marketplace? Once you have one in place, what's the average life expectancy?
So there are sort of 2 strategies that we use with these devices. The first strategy is a bridge to transplant. In a patient that has life-threatening heart failure, we'll put the device in long enough as a bridge until a compatible heart becomes available. Those patients can be on the device for a matter of days, some of them for a matter of years. The second strategy is what we call destination therapy. So we put the device in and we leave the device in permanently, and they'll live out the duration of their life with that device. In general, patients are living about 2 years. 75% of them are living about 2 years. That being said, there are reports of patients living more than a decade, and there's a handful of patients that have lived 15, 16, 17 years. But in general, the duration of one of these devices in a patient is somewhere around 2 to 4 years. But again, that's largely limited by the number of adverse events that they're developing, which frequently contribute to their mortality.
So what do you think the impact of a TORVAD would be on that number? 2 years would go to what, you think?
So it's hard to predict that. If you take adverse events off the table, so disabling stroke, gastrointestinal bleeding, infections that can turn from a small infection around the drive line, which is the electrical system coming out of the body that drives the system, but can then enter further into the body and create sepsis and instability. If you take all of those off the table, there's no reason why a device like this wouldn't function well in a patient for many, many years, and I would say more than a decade.
Right. So why is there only one device on the marketplace today? What do you think is the issue there?
That is a great question. It's a complex question. Up until about 1.5 years ago, there were 2 devices. There was the HeartMate 3 and then the Heartwear HVAD. The Heartwear HVAD had some issues, and as a result, it was taken off the market, and now the HeartMate 3 has a monopoly. Certainly from the standpoint of competitive development of new technologies, it sort of boxed everyone out. And so as an end user putting these in patients, not having different options to put in different patients in order to optimize outcomes and really sort of fit the right device to the right patient, with only one option, we have to treat everybody exactly the same. And so this is a situation where we need other devices, we need other technologies in order to change the landscape.
And how easy is it to use the current device? How big is it, and how long does it last, and how easy is it to implant?
Yeah, the implantation is similar to past generation devices. Again, you open the chest, you put them on the heart-lung machine, you implant the device. The device itself is a little bit bigger than a tangerine. They're designed to be quite durable. So these devices, will go more than a decade without having a device failure. But again, the reason that patients are not doing well and usually don't live that long is because they have all of these adverse events that are life-changing and oftentimes life-limiting.
Great. And so what about got questions from the audience? The Medtronic HVAD was a continuous flow pump also, is that correct?
That is correct. It was similar to the HeartMate 3. And again, because of patient outcomes and difficulties with the pump, it was taken off of the market.
Great. Do you think they're going to come back with an improved version, or how long will that take?
I hope so. Heartware had multiple other devices that they were sort of working on. I participated in the development of some of those. A few of them had small clinical trials. There were problems with each of them. Many of them have been shelved. And so, from the standpoint of the next generation continuous flow or impeller-based device, I don't know that we really anticipate any specific device is up and coming, which is why it's so important for us to really push forward a new technology, a new flow mechanism, something like the toroidal flow TORVAD, in order to demonstrate to the field you can pump blood safely and maybe even better than what currently exists, and force the field to acknowledge we can do better, and then the next generation devices will come out that are safer for patients.
Does the HeartMate have any communication capabilities, Wi-Fi or anything that communicates out its status or the state of the condition of the heart or anything like that?
It does. So it has features where the end user is able to know what's going on. You can upload the patient logs. There is information transfer with that device.
Okay, great. And what else do physicians look for in these devices that would be helpful to them in the diagnosis or just checking in on the condition of the patient?
From my standpoint, the number one important thing is safety. We see patients coming into the emergency room all the time with strokes, GI bleeds, infection, right heart failure, and we readmit them to the hospital. We manage them. Frequently, they're life-changing, and it's very difficult. So, the number one thing that I want is for these devices to deliver adequate blood flow to keep the body alive without causing all of these adverse events.
Right. And so what do you think is the next step here with the TORVAD as far as industry acceptance, or does it already have industry acceptance?
So we've shown the benchtop blood trauma data. It's been quite well accepted. There have been numerous animal studies. The next step is to do a clinical trial, to do a first-in-man clinical trial with a small cohort of humans, prove safety, and then have allowance from the FDA to do a larger clinical trial. I think Richard will be able to comment in much more detail about the next steps in terms of development and transitioning from animal models into a human trial.
Carlo, could I ask a question?
Sure.
You put a HeartMate 3 in and you set it at, let's say, 5,000 RPM. How often do you change the flow rate to sort of optimize its capability for a given patient?
Right. So this is a great question. Early on in therapy, it can be quite often. As I said earlier, the current generation continuous flow devices are not smart. You put them at one speed and they stay at one speed. And so early on, when you put it in a patient, as their body gets used to the higher levels of flow, as you figure out how to unload the heart appropriately, as you manage the right side of the heart, because now the loading conditions of the left side of the heart have changed, over the course of the first few weeks and few months, it's common that you have to make changes and find that appropriate balance so that the heart is happy, the vasculature is happy, the blood pressure is normal, and the kidneys are seeing enough blood flow that the kidneys are happy. And so there's a lot of interrogation, there's a lot of investigation in order to get that patient to a safe platform so they can go home and do well. This is one of the reasons why having a pump that's smart, that can sense when there are changes in blood flow and loading conditions, would take away a lot of the investigation, give safety earlier on, and probably allow the right and left heart to have appropriate loading conditions that would allow the patient to be safer and to do well.
So what you're saying is that if the patient, for instance, is set at 3,700 RPM and then gets a bit of a cold and goes to the drugstore and gets some Sudafed and some niacin, and their peripheral resistance shoots up, It
Right.
wouldn't be unusual for them to have a very high blood pressure, which might lead to a stroke. Is that not right?
That's exactly correct. And frequently we have patients that come into the heart failure cardiologists with a urinary tract infection, or they've had, an especially large salty meal and their blood volume goes up, and now they're having some alarms on the device. They may have some symptoms. The cardiologist has to put an ultrasound on the heart, look at the device log, and then maybe change the settings in order to accommodate these new conditions. With a smart pump, the device would just automatically do that.
My last question is, are there any other choices someone has besides an LVAD, aside from a heart transplant? If they can't get a heart transplant, they do the LVAD. If they can't get the LVAD, do they have any other choice?
But frequently these patients die. There are a large number of patients that are either ineligible for a heart transplant, or there's not an organ available to them. Many of them are not referred for this type of technology. The reason being that it's fraught with adverse events. And so there are many community cardiologists who would rather give their patients what we call maximum medical management with drugs, try and relieve as much of their symptoms, but ultimately those patients will pass because those cardiologists don't refer them in for what is, invasive, high-risk surgery, complicated by all of these issues afterwards. And so one of the things we talk a lot about in the field, and I think there are a lot of heart surgeons and heart failure cardiologists who believe this, if we can eliminate all of these adverse events, we're going to have a lot more patients that are referred in for this technology. And so a lot more of these devices will be put in. And so certainly a device like the TORVAD, if in fact the adverse event profile is very different and much better than the current generation pumps, could potentially go in a lot more patients than are currently receiving the HeartMate 3.
Does the size and weight of the HeartMate 3 keep patients away from LVAD technology? Is that an issue?
I'm sorry?
Does the size and weight of the HeartMate 3 keep patients from choosing LVAD technology?
The weight of the patient?
No, the weight of the device itself.
The weight of the device, it's a small device. We can put that, into many different size patients. And in fact, large pediatric patients, you can squeeze a HeartMate 3 in. So the device size is not the issue. It's the mechanism of flow that causes these adverse events.
What about the battery packs and the controller and all that, lugging all that around? Is that a turn off or not?
Right. I mean, with the current generation devices, there's a drive line that exits the body. They plug it into a controller and battery packs, so they're mobile. They have, 8 to 10 hours of mobility. They can walk around, they can live their life, but at the end of the day, they are tethered to a system that's external to the body. And so, one of the ways around that is to develop a transcutaneous energy transfer system. So this is much like you charge your cell phone, you put it on the receiver and it gives energy across the surface of the device. We have that technology for these devices, and it's already been proven. Certainly that's one of the goals for the TORVAD, is ultimately to develop transcutaneous energy transfer. And so patients won't have a drive line exiting the body. The system will be entirely implantable. And when they get in bed to sleep at night, they basically put the charger on their skin. It charges across the skin to the system, which is inside of the body. And then when it's charged, they can go about their business and not have a line coming out of their body.
Great. I think that's it for the questions. Thank you, Dr. Bartoli, for the great presentation there. With that, we'll move to our next presenter, Dr. Smalling. If you could, love to have you come up and tell us more about Windmill Cardiovascular.
There's not much for me to add to what Dr. Bartoli's already told you, but our company was formed over 20 years ago, and the idea was to make a safer, better, more efficient LVAD, and we actually have been able to build a pump that has never been built before, and you've seen it in action with Dr. Bartoli's slides. he's already gone over the continuous flow pumps and all the problems they caused, and he's talked about the mechanism of pumping, and so we'll go through that. So one thing that he didn't mention was we have an EKG lead that we suture to the surface of the heart, which transmits the electrical impulses from the heart to the pump and allows the pump to make decisions on when to pump and how much to pump and so forth. And in addition, it has the ability to measure the transpump pressure, which also allows it to detect low blood pressure or high blood pressure and adjust the pump's function based on those inputs. And at the present time, no one has anything like that. He's already gone over the blood trauma, which is far better with the TORVAD than with the HeartMate 3. You can see the peripherals. This is what I was talking about. It's about 5 to 6 pounds of stuff you have to haul around if you have a HeartMate 3, at least at the present time. And by virtue of the fact that we only require about 2 watts of power instead of 6 to 8 watts of power to run, we have a much smaller controller and battery pack. And we also are developing a transcutaneous system. Dr. Bartoli has shown our fish video. This is a little repeat of the blood trauma. But in addition to the blood trauma testing, we've implanted our device in over 50 animals, both acute and chronic animals, the longest up to 60 days. We've had no significant thromboembolic events, no real major problems. In addition, we've done mock loop testing with over 20 months of continuous pump function with varying loads on the pump, and have had no controller failures and no pump failures. We also have done accelerated wear tests that predict the piston mechanism has at least a 40-year hydrodynamic bearing life. So that has been robust. Dr. Bartoli actually also assisted us in some cadaver sizing, and we demonstrated that with a simple lateral thoracotomy, we could implant our pump. All of our pumps have been implanted without cardiopulmonary bypass, and it takes me, an interventional cardiologist, to implant one about 90 minutes. So if I can implant it in 90 minutes, I'm sure a cardiac surgeon with Dr. Bartoli's skills can do it a lot faster. He also mentioned the ability of our pump to change function. And what you can see here is that we transmit from the pump to the control center every 8 seconds, the blood pressure, the heart rate, the motor currents in the device, and a number of other pump parameters. And if they're also built-in alarms if there are abnormalities in these functionalities. So the slide on the right shows physiologic tracings from a sheep that we implanted several years ago. And immediately after implanting the pump, for whatever reason, the sheep was up and eating and doing well, but its blood pressure was almost 200 millimeters of mercury, and its heart rate was also over 160. So at that point, the pump said, I don't need to support this animal. I'm going to go into my sleep mode, which is pumping 1 liter a minute very slowly. As the sheep started to recover and the blood pressure came down, the heart rate came down, it then sensed that and went up to 1 to 2 pumping, and then subsequently with further improvement in status, it went up to 1 to 1 pumping, all automatically and instantaneously. So it instantaneously knows exactly what the body should have and corrects its function based on that. We talked about the 2-watt power versus 6 to 8 watts power, and one of our engineers has developed and has a patent pending on a transcutaneous system, which is very small, very compact, and highly efficient. And it would allow the patient to go to bed with a charging antenna under their bed, charge up their pump while they're asleep, and get up and have 6 or 8 hours of function without a recharge. So that I think would give people a tremendous ability to get up and around and do their usual daily activities. For instance, people with a HeartMate 3 can't go swimming. They can't do vigorous exercise for fear of getting driveline infections and so forth. And this would eliminate all those issues. We have 3 generations of the product. We'll talk a little bit about that, including the current TORVAD, the TORVAD implantable, which is a transcutaneous powered TORVAD, and also a pediatric / small pump for smaller people like women. And for particularly, we have a number of patents and a number of pending patents, and landmark analysis have been good, saying that basically we have IP that is completely separate from anybody else and without any challenges. We've been invited to present at almost 30 scientific meetings, have 10 publications, and we have contracted with MICRA, which is a regulatory company founded by the fellow that used to be the head of the circulatory devices branch of the FDA. And we've contracted with Valenium, a local Houston-based company that does medical device manufacturing. And we, with sufficient fundraising, we will be able to get these 2 involved so we can accelerate our journey toward first-in-human applications. At this point, I'm going to turn it over to our financial people. Sam, would you like to join in here?
Sure. Absolutely. Thank you. My name's Sam Liang. I'm a business and strategy advisor that's been working with Dr. Smalling over the last couple of years on the Windmill as it develops the TORVAD technology. As Richard indicated, we've done landscape work on the IP front with Lee and Hayes, and have demonstrated that there's very little to no overlap versus any other strategic or startup that's working in the LVAD space. As part of due diligence around the company, we've done extensive voice of customer work with all of the thought leaders and key opinion leaders in the LVAD space. And the key takeaway as you read through each of these individual quotes is that, if TORVAD were able to get to the marketplace and the value proposition that we presented certainly plays out, this would certainly become their frontline therapy over HeartMate 3. The second takeaway is that besides it becoming their frontline therapy for all the various reasons that have been articulated, this would also expand the penetration rate and use of LVADs into a broader patient population. When you're looking at the financials of the market, the current market today is $1.1 billion with 600 million in the US. And as we've explained, there's only one player in this entire market, which is Abbott with the HeartMate 3. As we look towards the unmet need, I think we've spoken about the number of patients, which is about 50,000 patients that could actually utilize the device. The penetration rate is actually quite low, with only 9% of that patient population achieving or getting an LVAD. If you were to look at the total available market, though, in the United States, it's actually over $6.4 billion. When if TORVAD comes to market, it has the ability to take HeartMate 3 share, as well as to expand the market. And we would project that the market size would, more grow to over $9.5 billion, as well as, and we've conservatively shown a moderate penetration rate of the LVAD population, of the population that could achieve LVAD. So really big upside in utilization in terms of impacting quite a number of patients. What the company is looking for right now, it's currently raising $7 million. The use of funds is first to hire an experienced CEO, as Dr. Smalling is still a full-time practicing cardiologist seeing full patient loads. And as Dr. Smalling spoke about, it's to execute 2 agreements with 2 qualified suppliers. We've spoken about MICRA, where the primary advisor was the former FDA reviewer who used to approve LVAD devices in the FDA, and Valentium, the Houston-based center that has implantable products experience. As a side note, Valentium's chief technology officer, who would be driving this project, he previously worked at several LVAD companies. Together with the Windmill team, they would execute the work to finalize the design, conduct the formal GLP animal studies, and prepare for the first-in-human studies. One thing to note at the very bottom of this slide is the exits in this market due to the unmet needs. They've all been in the billions of dollars. Abbott acquired Thoratec for $3.3 billion, and Medtronic, as we spoke to earlier, acquired Heartware for $1.1 billion. From an exit dynamic perspective, many of the strategics have call points in the cardiac surgery area. And in discussions with many of them, they simply have said, we're currently too early. We need to get first-in-human data for them to attract additional interest in them looking at hardware. So in Windmill. As a result of that, we're out raising the funds to get to the first-in-human. As we look at the Series C and the $7 million, and what we anticipate as far as the raise going forward. The $7 million will continue to fund company operations from 2024 to the end of 2025. As we've spoken about the use of funds, it is primarily to hire the CEO, execute the contracts with the key suppliers, and complete the final design of the TORVAD technology. After the $7 million, the company anticipates needing an additional $13 million to go to the first-in-human trials. You can see the breakdown here at the bottom chevrons, $9.5 million to go through design verification and file the first-in-human IDE. And then the clinical trial itself would be about $3.5 million. The reason why the costs are so low is that in the heart failure space, in the LVAD world, CMS actually pays for the device and reimburses for the device in the clinical studies. Our current plans have us doing anywhere from 3 to 8 patients as part of the first-in-human EFS trials. Upon successful completion of that, we would then go through and pursue to file a full PMA, an IDE PMA submission to conduct a larger clinical trial in the 2028 to 2030 timeframe, with an anticipated approval in the 2030 timeframe. The U.S. pivotal study we currently estimate to be conservatively around $45 million. We do believe that the cost will actually be lower. The considerations that we currently have is funding a randomized controlled trial versus the HeartMate 3. However, we've had indications from discussions with the FDA that a single-arm performance goal-driven study would be acceptable, given the amount of data that exists on the HeartMate 3, in which case the cost of that $45 million would be considerably lower. We're currently sourcing funding from the various sources of funding. And obviously from a liquidity perspective, post first-in-man, once we get human data, we believe that we would certainly be a candidate for a continued VC and strategic financing. We could actually do an IPO to fund the US pivotal. And then I also work I work as an operating partner with Revival Healthcare Capital, and we actually have an investment vehicle by which, if a strategics express interest, we would do a structured exit and negotiate and discuss that at the point in time of the completion of the first-in-human, after the completion of the first-in-humans. So in summary, I think you've heard today very compelling arguments regarding the unmet need, the issues with the current device, how Abbott HeartMate has done a good job optimizing, doing all that they actually can do with the continuous flow pump technology. However, there's still a large unmet need with respects to safety events. and that the TORVAD technology, with this first generation, all the way through to multiple generations, could essentially become a valued player in the marketplace. Thank you, thank you to everyone for listening to our company today. Richard, I'll turn it over to you for any other closing remarks.
I think Dr. Bartoli did a great job. I wondered, Carlo, based on what we've just covered, do you have any additional comments?
So just to reiterate, you know, a patient comes in, advanced heart failure, heart transplant ineligible, or maybe they're eligible, but they have to wait. I can only offer them one device. It's a device that's fraught with problems. I know, and they know, that it's going to be a long road. They're going to be bouncing in and out of the hospital, and one of their adverse events may kill them. The field urgently needs devices that don't cause all of these problems. And I would go so far as to say the adverse events that the current generation devices cause are choking advancement of this field. And so we need a device like the TORVAD, which is specifically designed to completely change how blood is flowed, how the device works, and the adverse event profile. So I'm hopeful that, you know, this technology and this project will continue. At the end of the day, you know, the field needs novelty in order to move forward, in order to take better care of patients and see them do well.
I had a question. How much do these devices normally sell for on the open market, like the HeartMate? How much are people paying for that?
Sam, you want to answer that?
Yeah, so the reimbursement for the procedure right now, the DRG actually pays the hospital, I believe it's somewhere around anywhere depending upon the hospital where it's located, $190,000 to $200,000. The HeartMate 3, I believe, is about $125,000, $130,000.
And you mentioned reimbursement. What percent are they reimbursing?
They pay for the whole device if you're Medicaid, if the Medicaid patient.
So Medicaid pays everybody for that device.
Yeah, I believe so. I mean, yes. I don't know. Carlo can comment what happens at his institution. It does vary by whether you're in, you know, New York City or you're in Idaho. You know, there are varying rates, but essentially it is a fully reimbursed procedure.
Is that usual to have a device that's fully 100% reimbursed all the way through? Is every condition like that, or is this a special case?
Carlo, you want to answer that? I do not know the answer to that question, but I've also been quoted, you know, in the range of $180,000 to $200,000 for each of these devices.
Yeah.
So if anybody wants a device, they would get the government paying for it.
Yeah, to answer your question, it's not a special, you know, the way that our healthcare system, you know, works. This device is fully covered, and it's not unusual for a device that's been out on the market for so long. You know, this therapy has been available for over a decade, and so the government reimburses it. And that would be true for other, you know, very expensive therapies that have been out for this long.
It seems like that would make it very attractive to an acquirer to have such a high dollar valued product that's fully paid for by the government. You don't see that in every case out there. It seemed like they would be excited about that.
100%, you know.
Okay, great. Cool. Well, I think we're at the end of our time. I want to thank everybody for their presentation and the good questions today. I think with that, we'll go ahead and wrap it up. I want to thank Dr. Carlo Bartoli for your presentation. Dr. Smalling, thank you as well. Sam, thank you for your financial review of it. It's a great area to consider and learn more about, and we're looking forward to follow up with investors for next steps. With that, we'll go ahead and close it out. Were there any other questions? If not, let's go ahead and close it, and we'll see you guys next time. Thanks so much.
Thank you all very much.